Welcome to another explainer. I am so glad you're here. Today we're focusing our lens on a really fascinating and honestly an absolutely critical clinical journey. We're talking about the path to compliance in prenatal documentation. We're going to explore exactly how we accurately capture a pregnant patient's journey, literally, from their very first intake all the way through to clinical validation. And we'll be grounding this in Chapter 4 of the Guide to Clinical Documentation, along with the latest 2026 AHIMA and ACDI standards. So whether you're a clinician on the front lines, a medical coder, or a CDI specialist, getting this right is absolutely paramount. It's a real game changer for the entire health record. Here is a super quick look at our agenda for today. We'll start with 1, the foundation, move into 2, the blueprint, then cover 3, the context, 4, the assessment, and wrap up with 5, the integrity. Okay, let's dive right into this.
Before we get into the nitty-gritty specifics, we really need to talk about the canvas we're working on here. Whether a clinic is using old-school, simple paper notes or a highly complex electronic medical record system, standardized prenatal records are vital. I mean, they're the whole shebang. They don't just guide the clinical care, they facilitate this seamless transfer of information, they bake in risk assessment, and they ensure completely thorough documentation. Really, this standardization is your absolute best defense against any medical or legal ambiguity down the road. It essentially sets the baseline for the entire 9-month journey.
All right, moving to Section 1, the foundation, establishing the prenatal timeline and EDD.
So once a pregnancy is confirmed, there's this very well-established cadence of prenatal care that kicks in. It all starts with an initial, highly comprehensive visit somewhere between 8 and 12 weeks. From there, visits happen monthly up to week 28. Then we bump it up to bi-weekly from week 28 to 36, and finally, it's weekly from week 36 until delivery. Now, you might be wondering, why is this frequency so strictly structured? Well, it's because it allows providers to implement timely, risk-directed interventions exactly when they're going to be the most effective.
Now, at that crucial first visit, you also have to establish the estimated due date, commonly known as the EDD or EDC. This is calculated directly from the first day of the patient's last menstrual period. Let me tell you, this date is literally the anchor of prenatal care. Establishing a precise gestational age in weeks and days isn't just essential for keeping tabs on fetal growth. Actually, it is absolutely 100% required for accurate medical coding and clinical documentation integrity later on. If this is off, everything downstream is off.
Which brings us to Section 2, the blueprint, obstetric history, and the TPAL system. Let's see how this builds into documenting the patient's obstetric blueprint.
Okay, so this is a fundamental concept in obstetrics, but trust me, the documentation details really matter here. Gravity, or gravida, indicates the total number of times a woman has ever been pregnant. Parity, or para, reflects the total number of births after 20 weeks, and that's regardless of the outcomes. The big thing to remember, and this trips people up sometimes, is that a current pregnancy definitely counts for gravidity. Also, a multiple gestation, so we're talking twins or triplets, that only counts as a single event for both gravidity and parity.
And this brilliantly illustrates how we capture a complete, highly nuanced description of pregnancy outcomes using what's called the TPAL system. It breaks down like this. T stands for term deliveries, which means 37 weeks or greater. P is for preterm deliveries, so anything prior to 37 weeks. A represents abortions, which in a medical context simply means pregnancy loss for any reason whatsoever, including miscarriages. And L stands for live births, meaning the total number of currently living children. When you document TPAL correctly, you're providing immediate, incredibly dense clinical context for the current pregnancy.
Moving right along to Section 3, the context, comprehensive maternal and genetic history. That initial intake visit, it is incredibly data-heavy. It's a massive fact-finding mission. We need a highly detailed menstrual, medical, and surgical history. But we also run rigorous infection screenings. We're looking for HIV, Hep B and C, syphilis, rubella, and we also have to look closely at both paternal and maternal genetic risks, things like cystic fibrosis and sickle cell disease. And finally, psychosocial and behavioral screening is mandatory. Assessing things like tobacco use or screening for depression using tools like the EPDS, the Edinburgh Postnatal Depression Scale. Gathering all of this comprehensive data early on is what prevents adverse outcomes. And from a CDI perspective, it establishes a crystal-clear diagnostic trail in the health record right from day one.
Next up is Section 4, the assessment, the physical exam, and Bishop scoring.
So the physical exam generates some absolutely crucial baseline metrics. We record maternal height and pre-pregnancy BMI, we get that baseline blood pressure, conduct a pelvic exam, and measure fundal height and fetal heart rate.
Why is it so important to document all of this perfectly? Because things like extreme BMIs or early variations in blood pressure are prime triggers for future clinical queries. Establishing a rock-solid, accurate baseline is quite literally what allows us to track risk effectively throughout the pregnancy.
Now, what's really interesting about this next concept is how the Bishop score quantifies labor readiness into 5 distinct, measurable components. It's just a brilliant clinical tool. We evaluate dilation, so how open the cervix is, effacement, the percentage of thinning, station, which is where the fetal head is located relative to the pelvis, position, whether the cervix is facing anteriorly or posteriorly, and finally consistency, how firm or soft the cervix actually is. Each one of these components receives a specific point value based on the exam.
When you add all those points up together, the magic number you're looking for is 8. A Bishop score greater than 8 indicates a very high probability of a successful vaginal delivery. It's actually comparable to spontaneous labor. On the flip side, though, a score of 6 or less indicates what we call an unfavorable cervix. Documenting this specific score gives everyone on the care team a concrete, totally objective measure of the patient's clinical status.
All right, let's bring it home with Section 5, the Integrity, CDI, and 2026 Compliant Query Practices. Time to put on our CDI hats.
So a massive, absolutely crucial point here is distinguishing between pre-existing and pregnancy-induced conditions. For example, did the patient have chronic hypertension before conception, or is this gestational hypertension triggered specifically by the pregnancy? CDI professionals must actively query providers to make this distinction crystal clear in the medical record. The difference between these two scenarios radically impacts Uniform Hospital Discharge Dataset, or UHDS reporting, it impacts risk adjustment, and it completely changes the overall narrative of the patient's clinical complexity.
Under the latest 2026 AHEMA and ACDIS guidelines, formulating a compliant query requires strict adherence to these 4 steps. First, you must use a non-leading statement. You can't lead the witness. Second, you have to include clinically relevant indicators sourced directly from the medical record without adding any of your own subjective interpretation. Third, you provide clinically supported multiple choice options. And fourth, you must always give the provider an other or unable to determine option. Again, the goal here is to ask for genuine clarification.
This quote summarizes the ethical imperative of the 2026 standards just perfectly. Queries must be about achieving substantial compliance. They must never, ever mention reimbursement, quality measures, or denial mitigation. The entire purpose of the query process is to respect and capture the provider's independent medical judgment based entirely on the objective clinical indicators present in the patient's record. I want to leave you all with this somewhat provocative thought. When we take a step back and look at the prenatal timeline, that TPAL blueprint, all those rigorous risk assessments, and these compliant query practices, it really all comes down to accuracy. Is your facility truly capturing the full clinical complexity of your patients, or are you just grazing the surface? Because let's be real, the right documentation practices make all the difference in the world for patient outcomes and institutional integrity. Thank you so much for joining me today. Please like, share, subscribe to Decode Healthcare with Harshal.